All right, we're all set.
Okay. Marinus, how many people do we have registered?
20 plus. So far, 9 people have entered the room.
Okay.
And
Alrighty.
everyone is admitted. We can go ahead and get started.
Awesome. Awesome. Alrighty.
Good afternoon.
Good afternoon, everyone. Can you
Good
see?
afternoon.
Afternoon. Alrighty. So I'm just trying to fix my camera. Welcome to the JHPD Partnership for Excellence in HIV Care across Maryland. For those of you who don't know me, I'm Allison Agu. I'm the Program Director of the Pediatric Adolescent HIV/AIDS program here. My partner in crime is Marinus Terraforte, who is the Program Manager for Part D. And really, we're really excited to continue this virtual toolkit series. We've had great feedback and really would love to have additional engagement, et cetera, as we move forward. I want to hear your ideas of what you want to hear and feedback on what you have heard. So to remind everybody, our vision is to achieve a more coordinated response to HIV care by establishing mutually beneficial relationships that increase the quality of care that we provide as a community to the WICI population in particular, which is women, infants, children, and youth. Our mission is to build upon existing structures and systems to create a dedicated network of providers to coordinate across multidisciplinary systems of care. And so that multidisciplinary system and partners is all of you and us really working together to optimize our expertise, to engage and amplify what we know to help each other, help the populations of interest. Next slide. So hopefully you've had an opportunity to participate in some of the lectures that have happened before. And today is no different. It's going to be an excited one with Liz Prince. Prepping youth with Errol Field's last one was awesome. And looking forward, we have next month, David Griffin, who's going to do transition to adult care. And these go already booked out through September and adding more. And I'm going to expand not just the JH group, but Sinai, others. And again, if you're attending and you have something else to add, we want to hear from you. It's about amplifying our voices. Next slide. So today I'm
all the slides.
Excited to present Dr. Liz Prince, who is an assistant professor in the Johns Hopkins University Department of Psychiatry and Behavioral Sciences. Dr. Prince provides integrated psychiatric treatment to young adults with chronic illness, including sickle cell disease, HIV, and substance use. Shameless plug, she's our provider that works with us with our integrated mental health program. It's been fantastic to work with her. She's board certified in both general and consultation leads in psychiatry with expertise in providing psychiatric treatment in patients with complex medical conditions. And our research interests are understanding factors that contribute to adherence behaviors and how these relate to development and resilience. Liz, it's my pleasure to introduce you today to talk about stress and resilience amongst our young people and our WICI populations. Take it away.
Thanks so much for the kind introduction, and thanks for having me. I'm really excited to be talking with everyone today. If you'll just give me a moment, I'm going to share my screen and click a few buttons. Right, and let me make sure it's in the right format. And how does that look? Can everybody see my slides? Perfect. Excellent. I'm Liz Prince. I'm a psychiatrist. I work here at Hopkins, and today I'm going to be talking a little bit about stress and the COVID-19 pandemic. I'm sure this is something that no one has been thinking about or learning about recently, but my hope is that hopefully I can provide some new insights and perspectives on how I think about this, especially in our patients with HIV. I have no disclosures, and just to briefly review my learning objectives for today, I'm going to begin talking about what is psychological stress and what is psychological resilience. Summarize the literature of stress and what we know about stress during disasters, and then talk about what we currently know about stress during the COVID-19 pandemic. Focus in on the stressors and resilience factors in people living with HIV, and then conclude by reviewing a select few approaches to stress and building resilience in our patients. So to start out really broadly, what is stress? So originally the term stress was really came from the field of engineering, understanding how we understand how a material like stone or iron responds to strain under different kinds of conditions. The term sort of biological stress didn't really come around until more recently from an endocrinologist, actually, who noticed that if you have an organism and you upset or perturb it in different ways, there's sort of a standard set of responses, a sort of physiologic responses to that stress. So the physiologic stress response in people, we can see here in this diagram, there's sort of two mechanisms, a sort of shorter term quick response, which is mediated by the sympathetic nervous system, the fight or flight response that we know about. The sort of starts in the brain and ultimately results in the release of catecholamines like epinephrine and norepinephrine. And the response to these catecholamines is to increase your heart rate, increase your blood pressure, get some glucose going in your blood, and really set your body up to be able to run or fight or whatever it is you need to do as quickly as possible. There's also a longer term or a more prolonged response to stress that's mediated by the HPA axis that ultimately results in the release of steroids, the mineralocorticoids and the glucocorticoids. And these, again, are really preparing our body to sustain itself through a time of stress. Things like breaking down protein and fats for glucose so that you have energy, but also has effects on the immune system and on your blood pressure and things like that. I think it's important to really point out that these stress responses that we have are something that is adaptive. It's created to help us respond and be able to react when stressful events occur. This is the Yerkes-Dodson curve, or rather an animated version of it. And on the y-axis, we have performance from sort of a weak or poor performance to strong performance. Then on the x-axis, we have arousal or stress, really, going from low to high. And as you can see, in low stress in the far corner, there's performance may in fact be quite weak and poor, but as stress increases, there's an amount of attention and interest that also improves, and there's a point of sort of optimal performance when you have just enough stress to kind of get you to pay attention and do things and perform well. But if stress levels continue to rise, eventually performance becomes impaired because of just anxiety and overwhelming stress. To talk a little bit more about anxiety and the response cycle that we think about, especially as psychiatrists thinking about the response cycle of anxiety, we have an inciting or stressful event or trigger that results in an anxious interpretation and then ultimately may lead to avoidance. So an example I commonly give with patients is someone who's frightened of dogs. And so the stressful event is that they encounter somebody walking their dog on the street. They have an anxious interpretation of that experience, thinking that this dog is going to bite them or harm them, or that they're in danger because of this dog. Their anxiety will increase as they continue to dwell on the things that they're worried about that could go wrong. Ultimately, they may engage in a safety behavior or an avoidance, for example, crossing the street to avoid encountering a dog. And they will experience a temporary relief of anxiety, having sort of moved away from the anxious stimulus. However, this avoidance behavior actually perpetuates the anxiety. You never actually encounter a dog and have a good experience with that dog. And so you never sort of confirm that dogs aren't actually always dangerous. And you can end up in these cycles of avoidance. And certainly, missing out on the joy of spending time with dogs is a problem. But I think these kinds of anxious interpretations and avoidance behaviors become even more problematic when you're talking about avoidance of seeking necessary medical care or avoidance of getting a vaccine, for example. So these cycles of anxiety can create a lot of problems. when we talk about stress, it's sort of a slippery concept. So we talk about stress in terms of stress being something that can cause illness. Hearing, for example, about someone who has a heart attack after hearing bad news. But additionally, we also know as providers that illness itself is a stressor. And so I find that it's sometimes helpful instead to think of things as the stress response and stressful events to sort of be clear about what you're talking about when you're discussing stress. Moving on to talking about resilience, this is a topic that I've become increasingly interested in, and it's not just me. As you can see down in the right-hand corner, a recent PubMed search that I did shows the number of papers being published talking about resilience has increased exponentially over time. And this is something I know has also been in media. And I recently saw a big billboard over I-83 with something about resilience from Johns Hopkins. So I thought this topic is really, it's so important, we're putting it on billboards now. So it's similar to stress, though. I think that it is a slippery concept, and there are many different sort of definitions, although I think a lot of overlap. We can think about it as an ability to maintain or regain an equilibrium after an adversity. You'll see I've underlined after here. I think that it's important to point out that equilibrium may be lost during adversity. There may be stress, but this is talking about following adversity. Bouncing back from stressful, negative emotional experiences, having success despite a stressful event, bending but not breaking under stress, or even thinking of resilience as a protection from the negative effects of stress. There's a psychologist up in Canada, Dr. Unger, who has done some wonderful work primarily in children and young adults, but talking about what resilience is. And this diagram in one of his papers really illustrates that resilience is not a trait. It's not a thing that some people have and others of us don't, or something that you're allotted at birth and then doesn't change throughout the rest of your life. But instead, it's an interaction of multiple systems that all come together and overlap to sort of contribute to resilience in different kinds of stressful situations. So you can see at the core, there are biological systems, but there's also psychological systems. There's the social environment that someone is in. There's the built environment and then in the natural environment. And there's a complex interaction of these systems that work together in a process to create resilience. When we talk about resilience, a lot of times we think about what are the protective factors, what makes someone more resilient. And this is a list of a few categories. This is not an exhaustive list, but many researchers have found that social networks, having attachment to other people and relationships, are an important protective and resilience factor. Self-efficacy, the sense that an individual can do things for themselves and take care of themselves and make change in their life. Making meaning is also a protective factor. And when I say this, what I mean is the ability to understand a stressor as having some sort of meaning. This may be through faith or through a spiritual belief, or through a sense that there's a reason that difficult things have happened, or there's something meaningful or positive that can come out of a stressful event. The ability to solve problems, having basic needs met, and an important concept in resilience in all fields, including engineering and ecology, but also in psychology, is redundancy. The idea that if one system fails, that you have other backup systems in order to manage a disaster or a stressor. So now I'm going to move on and talk a little bit about the psychological response to disaster. In our School of Public Health, we have many wonderful people, including Dr. Everly, who is an expert in disaster psychiatry. And this diagram really represents the understanding they have of the phases of response to disaster. As you can see on the y-axis, we have emotional lows and emotional highs. And the x-axis really represents time. There are versions of this diagram where they actually do lay out a sort of timeline of after 1 year, you would expect this. But I think that each disaster and each stressor is different, and an expected timeline is not always realistic. But you can see these different phases beginning with the initial impact of a disaster, a time where emotions may sort of be going from high and dipping down, but followed by a heroic phase, a phase of people coming together and realizing there are things that need to be done. I need to pitch in, I need to help. And this may in fact lift mood or improve emotions. The heroic phase may be followed by a honeymoon period, a period where we're all in this together. There's a sense of community cohesion. We're going to face this disaster and be okay. The honeymoon phase is often followed by a period of disillusionment. As I was practicing giving this talk earlier this week, my partner came and pointed at the disillusionment phase, and he says, "This is where I am right now." And I think that's something a lot of us might be able to relate to right now. But periods of fatigue, stress, feeling overwhelmed, and emotional lows are associated with this period. Ultimately, this is followed by a period of restoration, working through the losses and grief that have resulted from a disaster, adjusting to the new circumstances, and ultimately rebuilding and a recovery of emotions. We do have, some understanding of how mental health is affected after disasters. And the first thing I want to highlight is resilience is common. Most people are not affected by mental disorders after a disaster. That does not mean that most people don't have emotional responses. Strong emotional response to a disaster is normal. And the trajectory of mental health and dysfunction after is similar to resilience, is multifactorial. There's many things that contribute, things like demographics, but also disaster-related factors, for example, how much someone is exposed to the disaster, what their social networks and support look like, but also if they have a history of mental illness or other kinds of mental health problems. So this diagram on the right is really just looking at the different sort of trajectories of mental health and dysfunction after a disaster. So on the y-axis, we see sort of dysfunction where higher numbers are worse, lower numbers are better. And then on the x-axis, we have 3 different time points following a disaster. So as you can see at the top with these filled black circles, these are a sort of chronic dysfunction throughout all 3 time periods. Whereas at the bottom with the diamond, you can see a group of people who are sort of resilient, a trajectory of sort of resilience throughout. And in the middle, different trajectories are expected of mental health. I think it's really important to understand that disaster cycles don't really translate perfectly to a pandemic. So this is a diagram. You can see there's an incident that has occurred, there's a response and a recovery, and in the outer circle is sort of the different phases of a pandemic. But I think it's more helpful to think about recovery from a pandemic as a sort of non-linear process. You have these different waves, you have transition periods, and really the duration of these transition periods and the sort of rate at which recovery is able to occur is really determined by so many factors about the political environment, the healthcare infrastructure, and many factors. So what do we know so far about mental health and stress during the current pandemic. So again, many of our colleagues in the School of Public Health have been doing some really great work. And so what we've seen is that depressive symptoms measured by the PHQ, which many of you I'm sure are familiar with, a sort of self-rating scale of depressive symptoms. And what we've seen is these have increased during the pandemic when compared with data collected from prior years. And that this is most notable in groups that are economically vulnerable. This diagram here shows on the y-axis, we have the percent of adults who have symptoms. And on the x-axis, we're looking at different categories. So for example, the none category, the first two bars, you can see that a larger percent of adults had no significant depressive symptoms before the COVID-19 pandemic, and then during the pandemic, a smaller proportion of adults have no significant depressive symptoms. And looking all the way over to the severe category, we can see that again before, as measured by the NHANES, which is a survey administered across the country, we can see that before the pandemic, the percentage of adults in the severe category was quite low, and that now during the pandemic, these same measures show a higher percent of adults with significant depressive symptoms. Another study done by our colleagues in the School of Public Health looked at levels of distress in adults with pre-existing psychiatric conditions, but also those who had a psychiatric diagnosis. And they did find that both groups had higher levels of distress, but it was even greater, higher risk in those who had a history of significant depressive symptoms. And we also know that isolation and quarantine are tremendous stressors that are likely having a moderating effect on these depressive symptoms. I looked into the literature specifically for HIV and seeing what do we know about stress being experienced during the pandemic for this for our population. There was only a few studies I could find, and they were for the most part in adults. There was not any in children. This was done by some folks down in Miami, where they did a sort of survey somewhere between May and December of last year. They did a single survey with 231 people with HIV and 42 people who did not have HIV. And what they found in this survey, they asked questions about loneliness and stress, but also depressive symptoms and the burden of the pandemic has had on their lives. They did not find between the people who had HIV and the people without HIV, there was no significant difference between markers of loneliness or stress. And similarly, between looking at men and women, they found similar levels of burden of the pandemic. However, for women, they did find that more women reported a loss of childcare and also a loss of their mental health care than men. There was a sort of significant difference between those. And then they also did see, when looking at how the burden of the pandemic related to loneliness and stress, there was also difference between men and women, such that the association between the burden of the pandemic and loneliness was significant for women, but not for men. And the association between the burden of the pandemic and stress was also significant for women, but not for men. Another study that was done in St. Louis at WashU, done a little bit earlier in the pandemic, in sort of April and May of 2020, again, doing a sort of cross-sectional survey with 133 people who were living with HIV and 54 people who were HIV negative. And what they found which is a little different from the prior study. They found that people with HIV had more depressive and anxiety symptoms and more loneliness compared to those who did not have HIV. This study was particularly interesting because in addition to the cross-sectional survey that they did in April or May, they also had information from prior visits before the pandemic. And so they were able to look at changes in symptoms between two visits. And they found that anxiety had increased more for people living with HIV. They also found some interesting things around substance use. So the tobacco and marijuana use had increased more in people living with HIV. And they also found that greater marijuana use was associated with really correlated quite strongly with higher anxiety and depressive symptoms. So moving on from the sort of data and studies that have been done, I think, how do we think about as providers how we can identify stress and protective factors in our patients with HIV? And I think a lot of these concepts are perhaps quite basic and simple, but still useful. I think starting out with who is the patient, what were their needs and what were their strengths before the pandemic? And quite importantly, did they have a pre-existing psychiatric disorder, as we know that those people are particularly vulnerable to greater distress during the pandemic? And what coping styles have been important previously? I find myself, I'm on the consult service at the moment in the hospital. So I'm often seeing people who are in a very difficult situation. They've been hospitalized. This is not the best moment of their lives. And I'll ask them, how do you normally cope with stress? Maybe you've never been in this situation before, but I'm sure you've had difficult life experiences. What do you know? What's your normal approach to that? And people might share a faith tradition or a family support or a physical exercise that they enjoy. I recently had a man, I think in his 70s, who shared he listened to the band Korn, and that was how he coped with stress. I found that to be quite striking. I would not have expected that response from him. So paying attention to who the patient is, what their strengths are, what their coping styles are, and what were the things that they need, were struggling with and needed before. And then what has changed during the pandemic? We know that social networks are very important in resilience, and how has their social network changed? We know from the study done at WashU that changes in substance use seem to be more prominent in people living with HIV. And so has there been a change in their substance use? And how has their access to care and other basic needs changed? Because these are important protective factors as well. Now I want to just conclude with a little bit of how I might talk to my patients about resilience. I think I put it as the last thing here, but it's really the first thing, which is that there's many different approaches to resilience. And so these are just some ideas, but certainly not an exhaustive or the only options. So I find it's helpful to explain that psychological resilience is something that can be developed, like building a muscle or learning a new skill, something that requires practice, like speaking a language or playing the piano. And again, the expectation for these exercises and approaches to building resilience is not to completely eliminate stress, but rather to equip people to handle spikes in emotion in a better way. A few examples that I'll talk about are gratitude exercises, information gathering, which I think has become very important during the pandemic, how to notice and label strong emotions, and then a little bit about self-care. Starting out with talking about gratitude, I think that even during stressful times, there are things to identify that one can be grateful for. These can be simple things like spending more time outside, being able to connect with your family in a way that you might not have otherwise, just the mundane experiences of the sun coming up every day, or the opportunity to give a talk with people that I might not have otherwise come into contact with. Finding a time of day or a particular circumstance in which you engage in these gratitude exercises, linking it to other routines, like when you get up in the morning or just before you fall asleep, while you're brushing your teeth, while you're logging into your electronic medical record in the morning. There are ways and times to sort of use gratitude exercises. Information gathering behavior is something that I've spent a lot of time talking with patients about recently. During, we can't control what's happening in the world. We can't control the information that we're being exposed to, but we can have some control over how we receive that information and how we react to it. Some of the sort of ways to sort of control that are choosing your sources of information, so choosing particular news sources or avoiding others that you might not find to be helpful or informative. Choosing how much time to spend gathering information on a daily basis. Not only choosing how often during the day that you're gathering information, but also choosing the time of day. For example, not reviewing the news at bedtime is a common thing that's come up, and sort of that particular time of day is perhaps a better time for a gratitude exercise than another look at the news. Emotion regulation. So I have some pictures here that I found from a group called Whiteboard Psychology, really depicting some emotions that I think many of us probably experienced during this pandemic. But everyone has a sort of variable emotional responses. Some people have very strong and intense emotions, and that is wonderful when they have positive emotions, and can be overwhelming when they have negative emotions. I think I'm getting a echo from somebody. We can mute. But what the sort of concept of emotion regulation is around sort of recognizing strong emotions and labeling them. Once you've recognized and identified and labeled these emotions, it can be much easier to apply techniques to sort of control the intensity of those emotions. And then just to talk a little bit about self-care, I think this is something that gets thrown out a lot, and certainly one might think about getting a pedicure or going on vacation or eating whatever food all of that is. But I actually think that self-care, when we're talking with patients, I think we can expand the way that they're thinking about it to include taking care of your health and your body. And that includes having a routine for meals, having a routine for sleep, having a routine for taking your medications and meeting with your doctors, and that these things all fit squarely within the category of self-care. It's not just about sort of luxurious holidays and things like that. Another thing when I'm talking with patients is again, this idea of what were their strengths and their coping approaches before all of this happened. How can we adapt those things and grow them? Having a consistent routine can be very, very comforting during times where everything else is changing. To highlight what resilience training isn't going to do, it's not, we've talked about how it's something that is a skill that is to be built. It doesn't immediately relieve stress or negative emotions. It doesn't guarantee that things will go back to exactly the way they were before. Sort of regaining equilibrium, if you will, it does not mean going back to the same. It just means having a sense of balance in the new circumstances that you find yourself in. Resilience training is not going to treat an underlying anxiety or depressive disorder. And in fact, it could be quite challenging for someone who's in the midst of a severe depressive disorder to be told, well, if you just had some more coping skills, you'd feel better. Like that might actually be sort of demoralizing in those circumstances. And I think we've talked a lot about resilience is not a trait. It's not a thing that somebody possesses or doesn't possess, or it's not just about an individual. It's multiple systems that interact. And there are issues in the social environment and the built environment and the natural environment that are going to contribute to somebody's ability to be resilient. No number of gratitude exercises can help someone who has no food. So just to kind of wrap up here, and then I would love to answer questions or hear thoughts. Stress, surprise to no one here, I expect, is that stress is indeed higher during this pandemic in the general population, but also in people living with HIV. And that I think as the pandemic continues, we will understand more information will be available about the trajectories of mental health during and after the pandemic, and resilience, which patients are resilient, or what situations help people to be resilient, and what might be more stressful. As providers, we have expertise in identifying stress and resilience in our patients. And I think that there are approaches to building resilience that we can adapt for our patients. I have some references here. I have some more resources and videos if anybody's interested. The first is Coping with Stress and Social Isolation by one of my colleagues, Dr. Schwartz. There was also the very first episode of this series. It was done by my wonderful colleague Anna Bow, our nurse practitioner, talking about provider stress and burnout. And then the final two links are links. First is for the World Health Organization, and then the next is for the School of Public Health. They're looking really at sort of large scale epidemiological data on what do we know about mental health during the pandemic, and what are we tracking, and what are we interested in. From my review of the literature, I think there's a great hole in looking for what's going on with our patients with HIV. And so I'm hopeful that more of this data can be looked at and published, and we can learn from it. That's all I've got. So I'm happy to take questions or comments. And then also I've included my email address here, so if anyone wants to follow up with this, anything I can help with.
Thank you so much, Liz. I will confess that your voice is so soothing. Even just talking and hearing you talk about stress, I feel a little less stressed myself. No, I really, thanks for awesome talk. I love the perspective that you gave, the history, what it is, where we are, and then strategies to cope. I think not just for our patients, but for ourselves as well. And I particularly love you're right, we think about stress release, and it's always, we're gonna go there and spend this money there, which in itself is stressful and actually limits the opportunities to actually reduce the stress. And so taking that out and saying, how do we make it every day, actually every moment, in terms of reducing the stress? I really do like that approach. Would love to open up for questions or comments for Dr. Prince. Was that good, Liz? But I think one question that I do have for you is, I think that sometimes, resiliency, we think about it in practice as oftentimes people have it or we don't. And I think people say, oh, I'm not resilient. How do you perhaps make that tangible for patients in terms of, well, you too are resilient, and how do you pull that out of them to help them recognize they too have that skill?
I think one of the great ways to do that is to really go into their life story and their life experiences and talk to them about what difficulties they've already faced in their life. And our patients with HIV who are coming to see us, I think that in and of itself is an example. You can say, well, geez, you have this terrible illness, and And you are demonstrating resilience by coming and getting care and treatment for that. That's an example of being resilient, to say, I've had this thing has happened to me that sucks. And instead of sort of going and hiding in a hole and not dealing with it, you're saying, I'm going to reach out for help and see a doctor or a provider or get help. So, I think it's much more meaningful if, that's a general one, but if you can find something specific, geez, remember when your mom died last year and you came in and we talked about it and you shared the sort of rituals and traditions your family had and how you got through that together. You can, we are all experts in our patients. We're not all psychiatrists. We're not all therapists, but we are experts in the people that we take care of. And so if you can sort of help them reflect back on the ways that they've faced adversity in the past. Certainly none of us have experienced an infectious pandemic before, but we have all been through difficulty and survived. So I think if you can point that out to people, sometimes that can be helpful.
It's almost motivational interviewing in some way, it sounds like. All right.
Absolutely. And I know you had a great talk on motivational interviewing too earlier. Definitely, I think the principles of supporting self-efficacy and really demonstrating to people that they do have self-efficacy, and what ideas do they have about how to face adversity, and supporting those ideas rather than putting our own ideas about how they can get through this is always going to be more meaningful.
Yeah. Looking back at the list of topics, I don't think I really realized how many were mental health focused as we were coming up with this. I think we're probably sending our own stressors, et cetera. And so it's really nice that these have been peppered with those kinds of talks that I think that have been really helpful. They're quite a bunch today. Usually they have a ton of questions. Going once, going twice. Any additional thoughts or feedback for those or questions? All right.
Well, I'll put my email in the chat as well, and anyone is welcome to reach out if they think of any questions or there's anything I can be helpful with.
Yeah, no, it was great. And thank you so much. And we will hopefully be tapping you for more. This was really fantastic. It was really appreciated.
Great. Thanks so much for having me. I hope everyone has a wonderful Thursday.
Yes. And everybody remember next week or next month is going to be David Griffith talking about transitions for youth and pediatric adult care. And really looking forward to hearing his talk. All right, everybody. Thank you so much for your time. You get 15 minutes back for your day. And to do something that release stress from you, taking some of the thoughts from them. All right, everybody, take care. Thanks again. Please fill your feedback forms out.